Hello, my name is Sharona Benheim, and I will be narrating a presentation on the neurosurgical management of intractable pain as an accompaniment to the Yeomans and Wynn Neurological Surgery, 8th edition, chapter 201. So I'll begin by speaking about patient selection for surgical pain therapies. In general, neurosurgical pain interventions are reserved for those patients in whom the treatment of the underlying cause of pain is either not possible or not practical or inappropriate. And for those patients who have tried non-surgical therapies and have not obtained adequate pain relief. It's critical that the treatment plan take into account the patient's big picture, including their medical history, their ongoing treatments, and especially their specific goals for the therapy. It is very important to identify comorbid psychological dysfunction with a formal psychological evaluation when appropriate, because contraindications to surgical treatment can include things like overt psychological dysfunction, like active psychosis, for example, major untreated depression and or anxiety, serious alcohol or drug abuse, and serious cognitive deficits. There are also relative contraindications or risk factors, which include other psychological comorbidities, including things like somatization disorders, personality disorders, major issues of secondary gain, unrealistic outcome expectations, or an inability to understand the purpose of the procedure or the device. And while those are not absolute contraindications, long-term treatment programs really must incorporate the management of these types of psychological issues into their treatment plan to facilitate a favorable outcome. To determine which therapy to use, one must first understand the predominant type of pain a patient is experiencing, as some therapies are known to be more effective for certain types of pain than others. The types of pain that we see can be grossly conceptualized as nociceptive versus neuropathic in origin, although confusingly these terms can be used often in more generalized context. In this context, however, nociceptive pain describes a situation that occurs when tissue injury or disease initiates signals that are transferred through the peripheral nerves to the brain via the spinal cord. These neurons can be located in the viscera or in the skin or the joint capsule or the periosteum, etc., basically within the somatic system. The types of sensations that a person will describe with these different pathologies really varies quite widely, but in general, visceral pain is characterized by being poorly localized and often has a deep, aching, squeezing characteristic, while somatic pain is often well localized and can be described as sharp or aching or throbbing pain or dull in nature. Some examples of visceral pain can include things like bladder cancer pain or pain from visceral metastases, for example, in the lungs. Examples of somatic pain can include skin lesions, like, for example, metastases to the skin or to joint capsules, or a very common form of somatic pain includes mechanical low back pain. Neuropathic pain, on the other hand, involves damage or dysfunction of the nervous system tissue itself. So this pain can be peripheral or central and has a somewhat different character than nociceptive pain, although this also can have a wide spectrum. It's often described as shooting, electric, tingling, or burning pain. Some examples of peripheral neuropathic pain can include radicular leg pain from a herniated disc, for example, or post-herpetic neuralgia or trigeminal neuralgia. Examples of central neuropathic pain can include post-stroke pain from a stroke, usually within pain pathways like the thalamus, or MS-related pain. Often we see overlap of these spectra and common pathologies that comprise both etiologies, like low back pain, for example, that can also have components of nociceptive pain from the muscles or joints and components of neuropathic pain from compression of nerves. We have a large armamentarium of surgical therapies that here can be loosely divided into augmentative therapies, which include neuromodulation procedures, where the nervous system is modulated typically with electrical stimulation, as well as neuraxial drug delivery systems, where the nervous system is modulated chemically. Relatively speaking, these augmentative therapies are usually preferred over ablative procedures because they're adjustable and reversible. However, there are many special cases, and in particular cases involving cancer-related pain, especially end-of-life cancer-related pain, where neuroablative procedures are the most effective and the most practical options. Ablative procedures can be extremely powerful and can prevent transmission of nociceptive signals into the CNS, leading to significant and often immediate pain relief. Both of these classes of therapies involve a variety of procedures that can be targeted to nearly every level of the nervous system. And it's important to know that while many of these therapies have been around for decades, outcomes of these relatively rarely utilized surgeries have traditionally mostly been in the form of case series and retrospective reviews. So data should be interpreted cautiously, and there's clearly still much to learn. An exception to this, notably, is within the field of spinal cord stimulation, one of the most common neuromodulation procedures we perform, where several randomized controlled trials have been performed demonstrating efficacy. Nonetheless, it is important to note that we currently do have in our neurosurgical armamentarium some very powerful techniques when they're used appropriately. There are many extremely powerful tools for the management, specifically of cancer-related pain, that are unfortunately undertaught and underutilized. It can be said, generally speaking, that these central ablative procedures that are listed here really, while they can be used for non-malignant pain, are largely reserved for cancer-related pain. And this is true for a variety of reasons. In some cases, because of the potential risks from the procedure, and in some cases, because the effects from some of these procedures may be short-lived, for example, lasting on the order of 6 to 12 months, and therefore may be a very powerful tool to help patients with severe pain at the end of their life. I'll start by describing cordotomy, which may be one of the most effective and underutilized procedures for cancer pain, as it has relatively limited risks and can be performed safely and effectively with a percutaneous technique under CT guidance with just local anesthesia. Usually this procedure takes about 1 or 2 hours, and its effect is immediate and dramatic. It can be used for a variety of pain types and locations, but it's best performed unilaterally to treat contralateral pain that is typically nociceptive in origin, and the pain does need to be localized to the hemibody, ideally even to a quadrant of the body. For example, an ideal patient for this procedure is one with intractable pain from a large right femoral head osteosarcoma. This, you can imagine, would produce typically nociceptive pain, and it's really localized to one region of the body. Midline myelotomy is a similar procedure to cordotomy, although it's typically performed in an open surgical fashion, although a percutaneous approach does exist, and generally is used to treat visceral pain, such as pain, for example, from cancer of visceral structures like the abdomen or pelvis. Trigeminal tractotomy is typically performed percutaneously and is used to treat intractable facial pain, typically related to cancer as well. Mesencephalotomy is a fairly rarely performed procedure that is used to treat head and neck pain. It's usually done via radiofrequency ablation through a cranial approach. It's important to remember intraventricular drug delivery. So just like we can place an intrathecal drug delivery system to deliver chemical neuromodulation to the spinal cord, the catheter can also be placed inside the ventricle for patients with end-of-life cancer pain, and this can be a very powerful tool to treat head pain or headache. Thalamotomy is also a less often performed procedure and can be used to target the sensory thalamus to treat hemibody pain. Hypophysectomy is also an underutilized procedure, which is done usually with a radiosurgical approach and is indicated for the treatment of pain related to diffuse, especially bony metastases. And finally, cingulotomy is a very powerful tool, is a treatment that ablates the bilateral anterior cingulate gyrus and cingulum bundle and targets the affective, emotional components of pain. And so this is ideally suited for patients with diffuse pain causing significant. I will now discuss some procedures with very specific indications, including one of the most common procedures we perform, spinal cord stimulation, which is performed for pain in the trunk or extremities and is very effective for chronic regional pain syndrome. It is most commonly performed, of course, for low back and leg pain, less often for neck and arm pain. DRG stimulation is a relatively new tool, can be very powerful for the treatment of CRPS and for pain localized to an extremity. Intrathecal drug delivery, as I already mentioned, can be a very effective tool in the spinal cord for treatment of cancer-related pain. It's becoming less and less common for non-malignant pain, but can still be nonetheless an important tool for intractable axial or limb pain for patients who fail other treatments, including spinal cord stimulation. And it's also very good for the treatment of pain associated with significant spasticity, as in those patients with spinal cord injury, because it can be, of course, used to administer baclofen intrathecally. Dorsal root entry zone lesioning in the spine is indicated for localized pain, can also be used for cancer pain, although less often, and is really typically indicated for the unique case of brachial plexus avulsion pain. It can be also used for the transitional zone pain after spinal cord injury. The special case of dorsal root entry zone lesioning in the nucleus caudalis can be used for intractable facial pain, particularly deafferentation pain. For non-cancer related pain and pain that does not meet one of the aforementioned specific categories, sometimes it's useful to think outside the box and take a hierarchical approach to management of these often very difficult to treat patients. In general, neuromodulation is preferred over ablative techniques in these instances, as neuromodulation technique can be adjusted or reversed. And furthermore, critically, most of these neuromodulatory treatments do allow for a trial period to determine if the treatment is effective before implanting it permanently. In general, intervention distally can be considered first. For example, with peripheral nerve field stimulation of the affected area of pain, if it is a type of pain that can be localized to one area, or possibly peripheral nerve stimulation. In these instances, there may be or may not be a role for peripheral ablative procedures, such as pulsed radiofrequency ablation of the nerve, depending on the specific circumstances. In general, if trials with these more peripheral therapies fail, one can consider more proximal interventions in the nervous system as appropriate, including things like spinal cord stimulation or even spinal ablative procedures if appropriate. And finally, culminating in therapies like deep brain stimulation of sensory pathways, including the VPL or VPM of the thalamus and the PAG, PVG. Motor cortex stimulation can also be considered in this category, although it is less often used. And finally, deep brain stimulation at other locations can be considered, particularly those locations targeting emotional and affective components of pain, like the anterior cingulate. In conclusion, successful neurosurgical therapy for intractable pain requires a careful selection of the patient and the procedure. An understanding of the biopsychosocial components of the chronic pain syndrome for each individual is critical for optimal success. And as you can see, many unique augmentative and ablative therapies exist, targeting all aspects of the pain pathway with the capacity to provide powerful pain relief in the appropriately selected patients. Overall, knowledge of just the existence of these techniques and their relative indications is essential for the practicing neurosurgeon. Thank you.